listening to another podcast from the Journal of Oncology Practice from ASCO. This is Dr. Bob Miller from Johns Hopkins and consultant editor at the JOP. I am really looking forward to talking to my two guests for this podcast. For the third year in a row, Elaine Towle and Tom Barr from Oncology Metrics are here to discuss their annual National Practice Benchmark Report, which is a highly anticipated report that comes out every year and is always full of fascinating insights about the state of oncology practice in the U.S. This fall, the JOP published two articles in two different issues that covered this year's NPB report. The full data report is in the November JOP State of Oncology Practice Supplement, and it's entitled National Oncology Practice Benchmark 2012 Report on 2011 Data. And a few months earlier, in the September issue, JOP published an article entitled Oncology Practice Trends from the National Practice Benchmark. I'll be asking Tom and Elaine about both of these articles in this interview. So let me introduce my two guests for this podcast. Elaine Towle is Director of Consulting Services for Oncology Metrics, a division of Altos Solutions. She has extensive experience as an oncology practice manager and consultant, and she's a familiar face at the ASCO annual meeting in many educational sessions on the business of oncology practice. Welcome back, Elaine.
Thank you very much. Pleasure to be here.
And her partner in crime is Tom Barr, General Manager of the Oncology Metrics Division of Altos Solutions, and a former CEO, Executive Director of a large hematology oncology practice in Fort Worth, Texas. Tom also has extensive experience with organizations such as MGMA and the ASCO CPC, and he's been involved in the preparation of this annual National Practice Benchmark Report for, how many years has it been now, Tom?
It's been 7 years now.
Wow, 7 years. Well, welcome to you as well, Tom.
Thank you very much. Pleasure to be here.
Thank you. So for the listeners who maybe aren't familiar with the NPB report, can you guys describe the survey a little bit and the population being studied?
Yeah, sure. Glad to do that. As I said, we've been doing this for 7 years, and in each of these 7 years, we've emailed invitations out to our mailing list of oncology practices. Of course, that list has changed a lot over the years, but for this most current report, we included a few over 900 practices and also about 1,400 individuals, and we invite them to complete this online survey. So our goal is really to reach as many practices as we can. And what we want to do here is create an operational set of benchmarks for any practice that wants to be able to compare themselves to sort of national averages. And we publish a good many of the benchmarks so you can sort of pick and choose the ones that may apply to your particular practice situation. Mm-hmm. And that set of individual benchmarks, I think of them as snapshots. That's the National Oncology Practice Benchmark, as you mentioned. Well, now we've done enough of these snapshots that you can put them together and make it like a little movie, like you used to do when you were a kid, draw the stick man and then
Sure.
Roll your thumb through it. Yeah. So now we can actually use that information for the trends article. So the respondents to the survey are really mostly private physician-owned practices, though we do have academic practices that respond and hospital-based respondents too. And I'd encourage all listeners to this to email me your name if you would like to be included in this year's survey, which will be coming out quite soon.
So how is this 2012 survey, which I guess I should point out is it's a 2012 survey, but it's on 2011 data. Is that correct?
Yes, that's right.
Yeah. Is this any different from the preceding surveys in years gone by?
Well, as much as we try to make it consistent from year to year, every year there are a few little changes. And this year we actually had a couple of big changes. One of them is that we really tried to restructure and reorganize the survey to help facilitate participation by hospital-based practices, other institutional-based practices who may not have access to discrete financial data that private practice oncology practices can get to. So we created something we called the minimum data set. And from that data set, we really can produce meaningful production statistics for all responding practices. So even practices who may not be able to provide some of the discrete financial data elements, if they can provide some productivity data, we can still produce some data for them. So we restructured the survey. We tried to make it a little bit shorter, which is not always successful, but we tried to do that this year. Another thing in our analysis this year, we decided to include all reasonable data elements, whereas in the past we really did some pre-screening work and only included practices that provided a complete set of data. This year, though, we decided to include all reasonable data. We ruled out data that just didn't make any sense or was not reasonably data that you would expect in the norm of responses. So that allowed us to include more individual responses in each data element. One of the biggest changes this year, though, is a shift that we've made in reporting drug revenue from reporting total drug revenue to reporting net drug revenue. That is total drug revenue less the cost of drugs. This really gives practices a more realistic look at their revenue, particularly at their drug revenue, and at the slim margins that are available in the pharmacy operation and practices. And lastly, we're now reporting not just an average for any particular data element, but also an adjusted average. And that adjusted average eliminates the highest and the lowest values reported. For most of the data elements, it doesn't make a really substantial difference, but for a few, you can see that by eliminating that high and low, you're probably getting a more realistic response for practices to use.
So you were just trying to cut out some of the outliers, it sounds like.
Exactly.
So I remember when we talked last year, you had made the comment that the 2011 survey, the number of participants was less than 2010. It sounds like this year was pretty comparable to 2011 in terms of number of responses.
Yes, just over 100 respondents from about 42 states, so it was pretty comparable. Of course, we'd like that number to be higher,
sure,
but it's pretty comparable to the previous year.
Well, that's good. That's good. Let me ask you about some of your findings. So one of the things that certainly oncologists are very interested is hearing about the business structures. And I think my take in looking through some of your graphs was that physician-owned practices, at least as represented by your survey, it still looked like that was the dominant business model, that it was, I think it was 76% were physician-owned practices in the 2012 survey, and it was just down a little bit from 86% the year before. And the other thing I thought was very interesting, I just want to get your comments on, is the percentage of buy and bill for drug procurement was still pretty high, it looks like. So let me ask Tom this. Do you think that this means that all the consolidations and mergers that we've been hearing about, maybe it's not hit oncology practices as much as people assume has happened?
That's some great observations there. And when you talk about what people assume has happened, I think when you hear about a consolidation or a merger or even a practice closing a location, that makes a big splash. But, in the overall scope of things, I don't think it really has become significant. That is, there's no wholesale move of independent practices into other arrangements. I think it is likely, though, that when a practice becomes merged with a hospital or perhaps merged into a much larger group, that they drop out of the survey.
I see. Okay.
So the trend to mergers is significant, and it may be real significant in certain market situations. I mean, it is a market-by-market phenomenon. Arguably, the ability to participate in the survey is really indicative of a level of practice management, which is more likely to mean that the practice can remain viable and independent. As you noted in your question, buy and bill accounts for a large proportion, 85% of these practices. And as we know, with margins as slim as they are, there's not a lot of room for error in buy and bill. You have to be good at it in order to survive it. And I think these practices that participate in the survey are good at it.
I think this is Elaine, and I think I would just add that Tom mentioned it's a market-by-market phenomenon, and I would emphasize that market share and local market conditions are really huge factors in this move from private practice to hospital. It really is the environment in which you practice. So practices are clearly becoming bigger, and some practices clearly are disappearing. They're either being purchased by another practice or being absorbed into the hospital. But I agree with Tom that I don't think we're going to, it's the wholesale shift that many people are discussing today.
I think you've clarified that it may be a little bit of an artifact of the people filling out this particular survey are more likely to be one type of practice versus another. They may not have the administrative knowledge if it came to a physician, say, if they're now working for a hospital to get the financial information to fill out the survey.
That's right.
Okay. So I was looking through some of your wonderful reports. I'd like to point out to the readers there are 89 figures in the data report in November issue. I think that's a record for Journal of Oncology Practice, Elaine. So props to you. Let me ask you about a couple specific things that kind of caught my eye. One was this concept of a WRVU, the relative value unit system. Can you explain what that metric is? And you talk about the standard of 7,000 WRVUs per FTU. Where did you derive that?
Sure. Well, relative value units are assigned to each procedure code or CPT code as part of the resource-based relative value system. That's the system that Medicare and many, probably most other payers use to determine reimbursement for procedure codes. In a very simplified explanation of the RVUs, each relative value unit includes three components. There's a physician work component, a practice expense component, and a malpractice expense component. There are some other things that factor into the calculation as well, but those are the three primary things. Productivity, particularly physician productivity, is measured using the physician work component of the relative value unit. So this WRVU represents work RVUs. And that's really becoming an increasingly important tool for oncology practices in all settings. It's used to look at physician productivity. It's used to determine physician compensation models in many environments. So we really focus on the work RVU, the WRVU, in our benchmarks. We started measuring work RVU a couple of years ago, and when we did it based on 2010 data, when we collected all of the data from the practices that reported, our average across the reporting practices looked like about 6,000 work RVU per full-time equivalent medical oncologist. So that's what we set as our initial standard as we considered work RVU. The 2011 data, however, supports a much higher work RVU as a standard. So we've kind of recalibrated, and now we're using 7,000 work RVU as the standard for the work and the benchmarks that we produce. Interestingly, there's a pretty wide range, with some practices obviously below that 7,000. 7,000 really is the average. But we also see some outlier practices significantly higher than 7,000 on the upper end of the scale as well. So we're pretty comfortable with the 7,000. And if you look at figure 15 in our data report in JOP, you can see that the 50th percentile, the average, and the adjusted average are all really right on that 7,000 point of the graph. So we feel pretty comfortable with 7,000 as a pretty robust average for this group.
And I gather there's a school of thought that the work RVU may be more reflective of physician productivity and maybe a more reasonable way of measuring physician compensation than just straight E&M codes.
That certainly is the trend in the industry, and we see that in practices that are talking to hospitals about perhaps changing their model and working differently with hospitals. This is a tool that hospitals have used for physician compensation for quite some time.
So talk about the revenue mix. I think this is, it's figure 29, and this is on page 58S of the November article. You give a pie chart of the revenue mix. So what were the different components by service line?
Sure. Really, the most important thing about this figure this year is the change that I talked about earlier. We changed from reporting total drug revenue to net drug revenue. So if someone tries to take this revenue pie and compare it to our previous reports and revenue mix, they'll see a significant difference in drug revenue, but that's because of the way we're reporting it now. So in the past, last year, for example, total drug revenue was a much larger portion of the pie. It was about 65%. But that included, we hadn't backed out the cost of those drugs. We've done that now. So this pie really paints a much more realistic picture with net drug revenue of 21%. Importantly, it's comparable to the E&M revenue, evaluation and management code revenue, as well as drug administration. So by pulling out the drug costs, it kind of equalizes the contribution of drugs, drug administration, and evaluation and management to the total revenue picture for the practice. Another thing about this is this revenue mix pie includes all practices in our study, including practices with radiation oncology. So you see a sliver of the pie for radiation oncology revenue. In another iteration of this work, we looked at just medical oncology practices, and the net drug revenue portion of the pie increased a little bit, but not significantly. So I think that this is a good way to look at drug revenue as compared to all of the other revenue sources in the practice.
Let me ask Tom about the practice expense side. So this was figure 42 on page 61S. Of course, I'd expect the drugs to be the number one expense, but I guess I was a little bit surprised that it wasn't higher than the 64% in that chart. What are your thoughts on that, Tom?
Well, as Elaine was speaking, that particular chart includes all practices. So it will include practices that have expense for radiation oncology and imaging and other aspects other than that cost of goods paid for, cost of drugs. So I think for a blend of practices, that 64% feels like a pretty good number. Certainly, if you were to exclude or include only practices with medical oncology, it would be a higher figure. But this feels like a pretty good number to me, that 64%. I think it's useful for all practices to look at that. Then you don't really have to sort out your components of costs that are from other product lines than medical oncology. Mm-hmm. So no real surprises there from my perspective.
Now, I thought one of the most interesting points of both papers was the important role that pharmacy operations continues to play as a key component of ambulatory practice. And one of the things you talked about I think it was a little bit of a new twist this year, was the role of dispensing pharmacies. So can you guys comment on that about, say, a practice is interested in dispensing oral drugs, and what are the important considerations that they need to think about?
Well, you're right. It is time to start to think about dispensing pharmacy. And really what's driving that is, as you say, that lots of orals on the horizon. So the first consideration is, what are the state pharmacy regulations that impact the decision for you to be able to do that in your marketplace? And then, assuming that it's permissible, the next issue is really volume. Like most things in oncology or even in medicine today, and with any new product line, you really have to have volume to make the numbers work for you. The margins are not high, and particularly with the orals, there are payer carve-outs. That is, where payers will require that patients get these pharmaceuticals from another source. And again, when you start to look at this type of pharmacy, it's a whole new inventory and reimbursement system. And while it's comparable to the buy and bill system, it really does require a new set of skills. So it's not to be undertaken lightly, but I think that it really is the right thing to do. Clearly, where we've seen this done, patients really do appreciate that convenience. And after all, the physicians, the medical oncologists, will be managing all of these side effects and are interested in compliance. So it makes a lot of sense to go down this road and look at this product line, assuming that it is permissible within your state licensure. Elaine, do you have anything to add to that?
No, I think you're right. I think we're increasingly seeing practices explore dispensing pharmacies and do that as a way to serve their patients and get involved in dispensing and have a little more control over the oral medications that are in the pipeline. And certainly there are a lot of them coming. So Tom's caution about state licensure and pharmacy regulations is important, though. And some states it's easier to do this than in others.
So, Elaine, if you look at the totality of the data analysis, being objective, what do you think the limitations of this kind of report are? And how are the data maybe not as generalizable as would be ideal?
Well, there clearly are some limitations, and we tried to acknowledge that a little more forthrightly in the paper this year. First, of course, it's a small sample size, and practices self-select to participate. We send our survey out, as Tom mentioned, to about 900 practices, and practices choose whether they can participate or not. the respondents are not the same from year to year. So even though the number is fairly consistent with just over 100 respondents, it's not the same 100 respondents. So that makes comparisons somewhat challenging, although, as you know, we make comparisons anyway and use the data as it's presented. The National Practice Benchmark has also been criticized as portraying only practices are doing well. And we acknowledge that. That may, in fact, be the case, that the practices who are healthier and doing perhaps doing better financially are the ones who have the time and the ability and the infrastructure to be able to participate. So we continue to report this data, and we hope that other practices can use the data in a helpful fashion for their own practice operations. But we do want to acknowledge that there clearly are limitations to the report.
So I'm going to make an honest man out of Tom now, because last year when we talked, you whipped out the crystal ball and you talked about things that were supposed to happen in 2011, 2012. And so I don't know if you're buying Powerball tickets, Tom, but you talk about in the trends paper. So this is in the September JOP. You made 4 predictions in 2011 that you thought we might see in this year. So can you go through those and be honest? Tell us how you did.
Yeah, I'm happy to do that because all of these predictions came true. Well, not exactly. That is, they were sort of true in their direction, but not in the quantities, not in the amounts of change that we expected to see. As you'll note, last year we'd predicted that the squeeze on operating margins would persist. And we had kind of a dire-looking graph showing operating costs and operating revenue crossing. And while that squeeze did persist, that is, it still is there, it was less severe than we had predicted. So there was an easing up of that squeeze, and in fact, in the article, I call it from the squeeze to the ease. It's interesting when you think about it. It's like when things are really bad and they get not quite as bad, then it feels much better. So relatively speaking, we did better. On the predictions 2 and 3, we said that we expected we wouldn't see efficiency gains, and by many measures, that was correct. That is, we didn't see efficiency gains in terms of work output per FTE in the whole practice or numbers of new patients. But as Elaine mentioned, we did see a substantial work RVU increase over the baseline of 6,000 that we'd seen in the year before, up to that 7,000. So we did see that increased a good bit. And as Elaine mentioned, when we look at the distribution around that average, there's some significant outliers in there that hint that perhaps even greater efficiencies are available. Prediction number 4 is we said that the squeeze would result in, or was be partially driven by, a relentless rise in labor and other costs. And we did see that. That is, that labor and other costs really did continue to go up. But the bottom line effect was mitigated by an increase in practice revenue. And that increase in practice revenue was greater than we had expected or than we had predicted that it would be. So all in all, we saw that the directions were pretty good. That is, we were heading in the right direction with our predictions, but the absolute amounts of the change were different than what we had predicted.
What about the drug revenues? There was the one graph I wanted to ask you about. This is figure 3 in the September article. It's on page 293 for our listeners. It looked like there was quite a drop, a perilous drop in the net drug revenue between 2008 and 2010, and then it seemed to spike up again in this 2011 report. Was that an artifact, or what do you think the explanation was for that?
Well, that's a great question, and it may be an artifact, but looking at that marginal revenue, it's extremely sensitive to bad debt. If a practice is more successful at making sure that they are not actually providing drugs to patients that they're ultimately unable to collect for on those drugs, then that net will go up dramatically. So I think that we're continuing to see an increase in the capability of practices to be able to manage for bad debt and to prevent bad debt from showing up on their books. In fact, Since the margins are so thin in medical oncology now on those drugs, I would say that you have to be good at that, almost perfect, in order to survive as an independent practice. So, as we said before, practices that participate in this survey are in business, and they've remained in business, and they're getting really good at this.
I noticed that the number of visits, I guess, was not all that different between the different years. And what do you think the explanation is there? Are there other efficiencies being gained that practices have sort of figured out in the last couple of years?
Well, that's another great question. This is my speculation, but I believe that really the increase in the work RVU, I mean, we're seeing higher work output relative to a fairly flat production rate on the number of patient visits, that really results from better coding for E&M services. And we've known for some time that there is defensive coding, that is, when left up to individual physicians to code the level of care that they have provided, that they tend to code lower than is reflected in the medical records of what the work they've actually done. So as we see an increase in the use of electronic medical records, where the coding is literally driven out of the clinical record itself, I think it's reasonable to expect that we're going to see those averages, that is, the coding levels for oncology, creep up. And I think that's the most reasonable explanation I can come up with for those two metrics, that is, stable number of patient visits and increasing work RVUs.
So it sounds like oncologists have finally figured out how to represent the work that they're doing and bill for it appropriately.
Well, and as you point out too, and the work has been represented in the clinical record, but in a paper chart system, the translation of that into a code is at the individual provider discretion. So I think we really are now starting to actually bill what we do more effectively than we have in the past.
Boy, we can do a whole podcast on this. We won't invite CMS or OIG to that podcast, but
I wish we would invite them.
No,
I
you're
think
right.
that they really need to understand this is not about fraud, or upcoding. This is about a good thing. That is actually getting the clinical work that we do properly represented in our billing codes. Then as we move away from fee for service into hopefully a more rational payment methodology, this will really kind of cease to be an issue.
So you sound pretty optimistic once again.
I am optimistic once again. And it's great to feel optimistic. And really the reason for that is, well, as I stated in the Trends article, I've started to think of oncology delivery system as an ecology. My early training was in the biological sciences, and I did a fair amount of work on ecologic systems, and I started to observe some of the same overarching principles about an ecology, an ecological system, as I think I see in these data as reflected over these 7 years. And that is that we have an incredibly viable and resilient delivery system, an incredible ecology. Now, in an ecological system, stresses increase the rate of adaptation. So then when an ecosystem is stressed, things start to evolve more quickly. Of course, that does increase the rate of extinction also.
Oh, wonderful.
I want to point out, and if there's too rapid a change, we can have, mass extinction, and we don't want that and don't see that really right now. And then when I single out some of the things that are kind of the most enthusiastic or optimistic for me, when we look at the outliers in the terms of work RVU, there's an individual practice that participated in the survey that both Elaine and I know well. And so when their numbers were just too high, we actually investigated with them to find out, well, what are you guys doing? How can you actually do this level of work? And we found that this is a practice that had really reorganized their workflow processes in the clinic to optimize the use of their electronic medical record and, importantly, of their non-physician providers. So this suggests that there are adaptations in our oncology ecosystem that can be maybe an order or two more productive and more value-laden than what we're doing now by looking over our shoulder. I made the bold statement in a meeting that there is no shortage of medical oncologists today, and there won't be one in the near-term future because these productivity gains are there and will be seized by practices that are capable of doing that. Yeah, I am. Warren Buffett and me, we're both optimistic.
You are. Your words are very reassuring, I think, to many people out in the trenches. So more power to you. Well, I know I asked Elaine last year if you're going to do this again. I already know the answer for this year. So tell me a little bit about your thoughts for the next survey, the 2013 survey.
Sure. Our goal, as you know, for the last couple of years has been to try and simplify the survey tool, hoping that will encourage more practices to participate. And we've made a little progress with that minimum data set that we developed last year, but we obviously still have some work to do on simplification. So we're continuing to work on that to try and make the tool a little easier and less onerous for practices. And we hope that will encourage more participation. That really is our goal, certainly is my goal, to try and get some numbers up a little bit higher, perhaps hear from practices that are in other practice settings, and perhaps some of the practices who may not be doing quite as well, so we get a little more complete picture of what's happening. So we want to continue to provide meaningful data for oncology practices to use in their daily practice, and hope that by publishing with JOP's support, publishing this information and simplifying the tool, that we'll be able to increase the participation. That's really our big goal this year.
Well, Tom and Elaine, I want to thank you very much for, as always, sharing your analysis and your insights and your great data for another year with our listeners.
Well, it certainly is our pleasure. We look forward to it every year and hope we can continue to collaborate in the future.
Exactly what she said.
So be sure to take a look at both of these manuscripts in the JOP, either online or in the paper issue if you're a subscriber. Again, the Trends paper is in the September 2012 JOP issue on page 292, and the full data report with the 89 lovely colored bar graphs and pie charts is published in the November JOP supplement starting on page 51S. And thanks so much for downloading our podcasts and for your readership of the journal. As always, please take a moment to send your comments and suggestions about these podcasts to jopeditorsdesk@asco.org. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thanks very much for listening.